You're probably wondering why an ophthalmologist is addressing you this morning. It's my pleasure to be and privilege to be the chair of the review committee for Dr. Ballermann. Think of an ophthalmologist as an internist who does procedures. So I'm also wondering why I was here. So it's a great pleasure to be here with you today, this morning, and thank you for coming, shoveling out snowbanks and the rest. It's a great privilege to present you to your department, Barbara, and to read your CV. I hadn't seen it before. And Barbara comes to us from many avenues. She did her undergrad here at the University of Alberta, went on to the University of Calgary to do her MD, and then went from there to the Royal Victoria Hospital, where I didn't realize we were contemporaries. And maybe just to, when we were on call at the Royal Victoria Hospital there was a very important show called Saturday Night Live. And we would all tell the locating operator that we were not to receive any pages except for cardiac arrests when Saturday Night Live was on. So my apologies, Barbara, if I did any misdeeds at the Royal Victoria Hospital. She went on from there to an accomplished career in the United States, went to Harvard to do her fellowship in nephrology, and in sequence went to a number of outstanding centers, Johns Hopkins, into the Bronx at Albert Einstein, came back to McGill, and then came here in 2003 to join the Department of Medicine with a joint appointment in physiology. She's been your chair for the past 5 years. I've had the pleasure of working with her as a chair. She's a wonderful person to work with, as you know. You can read her message to you. Her message is wonderful. It says, I want you to be good doctors, to be good teachers and mentors, and take pride in your discoveries and everyone else's. Such a nice opening for someone who's an accomplished clinician scientist. I love the nautical term on the end to say that, and sometimes in rough seas, as the ship is in the harbor and safe, what if the ships weren't actually built? And so I'm looking forward to finding out where she's going to take the good ship HMCS Medicine. Barbara, the floor is yours.
Thank you very much, Ian. That was a great introduction. And what I need to do to begin with, because I tend to get kind of mesmerized by detail, as some of you know, I want to just say this, that the last 5 years have been very, very brief. It has come and gone in a flash for me. But it has been a tremendous learning opportunity for me, and I've enjoyed it hugely. And my enjoyment really came from seeing all of the tremendous energy and talent that we have in the department, and all of the work that people were willing to do, even sometimes under fairly adverse circumstances, to help me out. In fact, I think this department obviously would be nothing without everybody in the department, with all the people that are doing the work. So I'm just this little person in the background who tries to make things smoother for everybody else. I'd like to also quickly give a very big thanks to my administrative corps. Barb Hiscock, you've transformed the admin corps, and I want to thank you for that, and all the people who are working with me up there. Now, I'm going to give you a little bit of philosophy mixed in with a little bit of detail and some numbers, because I always think that if we have any evidence, we should bring it forward, and we should have everything that we do informed by evidence. So the first question is, who are we? So I went back to an article which was published in the British Medical Journal in 2008, which really defined what academic medicine is all about. It's the branch of medicine pursued by doctors who engage in a variety of scholarly activities. And I think the operative word here is scholarly. And they highlight, of course, the three components of our mission, clinical care, research, and teaching or education. But they also highlight the fact that some of us, including me now, end up in managerial and representative roles. The other thing that was important for us to realize, and which all of you know who have position descriptions, is that the clinical workload for these doctors who are pursuing scholarly activities in an academic setting varies. And few academics may choose, and a few academics choose to abandon clinical medicine altogether. There is the odd person who actually does this and does a great job in whatever their other scholarly pursuits are. Every academic has a different work description, which is one of the many attractions of the academic career. And that is actually how we are composed. We all are slightly different. Okay. We do have a mission and a vision statement. These were hammered out before I became chair. We've recently had a strategic retreat where we decided not to go and recraft the mission and vision statements, because we felt that these types of statements should really endure over many years rather than being changed willy-nilly every few years when a new chair happens to think about doing a strategic plan. Because I don't think the strategic plan is actually totally incorporated in the mission and vision statements. The strategic plan really comes from what are you going to do to achieve those goals. Nonetheless, we all know, and we have stated, that our mission is to improve the health and healthcare of current and future generations through excellence and innovation in education, research, and clinical care. And the vision is to be recognized for innovative education, research, and clinical care, resulting in better health and healthcare locally and globally. And this to be recognized really has to do very, very much with scholarship. Because if we do what everybody else does and we do what is told to us to do, then we're not going to be recognized for being leaders. So this innovation piece then leads to recognition, innovation and dissemination, obviously. Okay. Okay, so the Department of Medicine currently is composed of 14 specialties and subspecialties, and I'll have a slide on this in a minute. We run the core program in internal medicine. So this is the foundational internal medicine training that residents receive right out of medical school. And we run residency programs for specialties and subspecialties. We do translational research that spans all the way from the structural biology of troponin to mitochondrial research, to endothelial research, which is what I do, all the way to the translation into the clinical realm, and now more and more educational and health services research. So it's the whole spectrum that we do. We don't just do one or the other type of research. Okay. We provide medical care for adult patients with medical diseases. That's pretty obvious. But there's a huge spectrum of the kind of medical care we provide. We give it in inpatient settings, in the ambulatory settings. We do quite a bit of distance care. We do direct medical care, and we practice consultative medicine. And we use pharmacological, procedural, and life-adaptive approaches to treat our patients. And these are usually not one or the other. This is usually done as a whole. Okay. We have currently 195 faculty members in the Department of Medicine. The distribution of rank is right here. So you can see that we have very many fewer assistant professors than the other two ranks. But this is normal because the assistant professorship really lasts only 5 to 6 years. And you can be at the rank of associate professor for 10 and up, and at the rank of professor forever. Well, at least until you die, or until you leave. By degree, we have 16 PhD scientists in the group who do not hold MDs and who are doing research. We have 4 pharm doctors in the group. They're all in cardiology. 17 of our MDs also hold a PhD, and the rest hold only an MD. We also count among our faculty, or in our department, 274 approximately. I don't know. We never know if this count is exact. but about 274 clinical academic colleagues. And here you see the rank of these people who are mostly fee-for-service doctors that are helping us teach and achieve our mission. Note, though, that the majority of them are either clinical lecturers, which is the lowest rank in this group, and or assistant clinical professors. And we've been doing a lot of work currently under the leadership of Jonathan Choi, but previously under the leadership of Shelley Duggan, to try and actually ask these people whether they don't want to be recognized for the work they actually do, because a lot of them do a lot of very, very good work. And it takes, a bit of courage to stand up for promotion, but we want to get them promoted. We have recently promoted a number of people to these upper ranks, and so we now have 24 clinical professors and 2 distinguished clinical professors in the department. When you look at these clinical academic colleagues, 15 of them are part of our ARP, and the rest of them work fee-for-service in the zone. And some people do a large amount of work for the Department of Medicine. Others do just a bit of clinical teaching. So there's a big variety of individuals who are part of the department. So I'm going to go back to this slide over and over again, and I'm going to just begin by talking a little bit about the managerial and representative roles in the department, so that you can see what we kind of do at the very upper, or I should say in the administrative service core, which is at the upper level of the Department of Medicine, because we're all now getting co-located in the Clinical Sciences building, and we are at the very top on the 13th lucky floor. Okay. So one of the very first things we did when I became department chair was we structured the department organization a little bit, we restructured a little bit to align ourselves with the kind of structure that already existed in the Faculty of Medicine and Dentistry. And that was to enable the people who were the associate chairs in the various areas to actually also sit on the committees at the faculty level. So we have an associate chair for education. That's Stephen Aaron right now. Evangelos Mikalakis has served as associate chair for research since the beginning of my term. Bill Defoe has recently taken on the associate chairship for faculty affairs, and it's really faculty affairs and faculty advancement or development. And Sander van Zanten is currently associate chair for clinical affairs. And you can see the structure underneath each of these associate chairs. Barb Hiscock serves as the assistant chair for administration, and she really orchestrates what's happening in the administrative core. And then this core serves the divisions, and the divisions are all headed by the division directors. And I think of this as a little bit of a matrix, because we do the administrative work in the department, and the division directors and division members interact with each of these components. So it's more like a matrix than it is an org structure. The components of what we do are shown here, and my whole presentation is going to be on it's going to be available to you, so I'm not going to read everything. But we have fairly well-defined terms of reference for each of the chairs and each of the committees that we've established. And then here are our divisions. So we have, and this is something that a lot of people really don't totally understand. The Department of Medicine is really the place that governs the core internal medicine program through the work of a very important person, and that is the program director for the GIM program, and that is Daryl Rolfson, who served since I became chair and who's been doing a tremendously great job. And he is assisted by Doris Kurtz in his role. Then we have a bunch of subspecialty divisions, and you'll see that I noted even internal medicine amongst these. internal medicine has achieved status as a subspecialty, and they now have a subspecialty program, which is led by Jennifer Ringrose, but Narman Kassam actually did a lot of the work to get them to subspecialty status. Then we have a number of the other subspecialties. So all of these subspecialties will admit trainees from the core medicine program. We also have a few specialty divisions. So this is neurology, preventive medicine, dermatology, and our most recent addition, physical medicine and rehabilitation. And they all accept trainees that have not come from the core medicine program. Okay? And you can see all of the people who are program directors and division directors here. Okay. So that's sort of the basic organization of the department. Now I'm going to turn a little bit to education and see what we do and what we might have accomplished. Okay. And over the talk, I'm going to show you some data from the years previous. Okay. It turns out that the Department of Medicine is involved in teaching at every level of the medical curriculum. And I'm only going to talk about undergraduate medical education and postgraduate medical education, although many of our members also do a lot of continuing medical education or continuous professional learning activities. When you look at the class sizes, we end up, each class is around 150 to 180, depending on where you are in the years. So it turns out that we have about 600 learners at the undergraduate level at any given time. And many of them are taught by our faculty members, both at the bedside and in the classroom. We also have in the Department of Medicine usually approximately 150 residents at any given time. And we have a few students that come to us through the foreign training program. So what do we actually do? Well, the faculty was kind to provide us with some data. And this is looking at the number of teaching hours that are provided by people from various departments. And as you can see, the Department of Medicine provides more than double the number of teaching hours compared to any other department. Now, of course, some of this is volume, but this is actually per FTE. This is a much larger amount than other departments provide. The green here refers to those departments that have ARPs. So this, and I'll get back to our ARP, this really shows us that the ARP has been instrumental in helping people to use or to put away some of their time for the purpose of undergraduate medical education. And here is the other slide that's interesting. This also refers to the value of the ARP. And this is the number of what are called core undergraduate medical education individuals. So this is the number of FTE, or the number of people who actually have a specific role in the Faculty of Medicine and Dentistry to lead some core activity in undergraduate medical education. And again, the Department of Medicine has the most, but pediatrics, they're about 25% smaller in number, and they are providing a large number of these core educators, family medicine and pediatrics both do. And as you can see, all three of these departments have ARPs. So this speaks to the fact that the ARP is an instrument that can help us develop individuals who are going to be core educators for undergraduate medical education. Okay. Again, more numbers. These are our training programs. I'm listing them here by specialty and subspecialty. We usually have around 30 people, and it's moving up a little bit to 35 core internal medicine residents. So in each of the years, we have around 30. And then if you multiply that by the 3 years, you come up to around 90 to 100 people in the core programs. And they then move, about half of them will actually move into subspecialty training programs here at the University of Alberta. Others go elsewhere through the CARMS match. We have around usually between 20 and 27 at this point residents that begin any particular training program in any given year. Okay. We have paid in the last 5 years quite a bit of attention to educational scholarship through the organization of under the Associate Chair of Education. We've organized education in such a way that we have leaders for undergraduate medical education, for postgraduate medical education, but also for educational scholarship. And through a strategic plan that was developed before I became chair in education, they had identified educational scholarship as one of the areas that needed to be developed. So we ended up hiring through a search, Liam Rourke, who is our PhD educational scholar. And they have now formed a scholarship group that does research in education. And we've paid particular attention to the promotion of tenure-track faculty who are doing educational scholarship. So we've promoted a number of people on the basis of medical education. And I'm just going to give you one example. If you see examples and you're not one of the people mentioned through my talk, I apologize, but there are a lot of very, very good people, and I can only mention a few. But this is just one example of educational scholarship. So Anna Oswald was recently promoted to associate professor on the basis of her scholarship, and she publishes regularly in the literature of medical education. Okay. Now, this slide is just there to remind me to also say a special thanks to all the clinical academic colleagues that do the teaching. Because as you remember, most of them work fee-for-service. And it reminded me to look at the Hippocratic Oath, which said that one of the things we should do is to teach them. Now, Hippocrates referred to the sons, only the sons, not the daughters, the sons of physicians, okay? That the physicians who had been taught should teach the sons of other physicians this art, if they shall wish to learn it. So only to those who really have an aptitude and want to go that, but without fee or stipulation. So this has been something that is really a tradition in medicine, that we teach what we do without the expectation of payment for it. And so a lot of the clinical academic colleagues in our community are teaching our students and our residents, and they are paying for themselves by doing their clinical fee-for-service work. Okay, and that's often not recognized, and I think we should recognize that. Okay, what about clinical care, one of our main components of our mission? Clinical care in internal medicine is divided up into its specialties and subspecialties. And, you know, I always think, and there's a lot of talk these days about more and more and more prevention. We want to do more prevention so people never get to the state where they have debilitating chronic diseases. But it turns out that our mission actually in the Department of Medicine is precisely to take care of those individuals who have complicated medical disorders. Okay, so we shouldn't discount the fact that that's what we do. Of course, we should also be doing preventive medicine, but preventive medicine spans into public health, into other specialties, and we must still practice our craft and what we're all about so that we can serve our patients. So we should be doing clinical medicine that is state-of-the-art, of the very highest quality. And when I say highest quality, we should be measuring this, and we should be getting back constantly to quality improvement. The way we practice should be innovative. We should be pushing the boundaries. We shouldn't be afraid that just because there is a limited amount of money nowadays that we can't be innovative. Of course we can. We have a tremendous amount of talent here, and we can be innovative, and we should continue to develop medicine. There should always be reevaluation and quality improvement, and we honestly should throw out those things that are just either not working or we're not really doing as well as we can. I find that, in fact, one of the difficulties is that people get wedded to the way they do things, and they're then not wanting, because it's so hard, to change. We should be meeting and advocating for our patients' needs at every level. So whether it's when I see my patient in the clinic or in the dialysis unit, or I'm talking to the Minister of Health about continuing care beds, for example, that whole spectrum is what we're all about. We should be mindful of our humanity, not only our humanity, but our patients' humanity. And this includes the end-of-life care that we should be providing. So there now is quite a bit of palliative care that is being developed in the Department of Medicine outside of oncology, addressing the end-of-life care of our patients. But we should also be mindful of our own humanity inside of what we do. So when our colleagues call us from Fort McMurray, panicking because they have a patient who's in acute renal failure, what I should be doing is, instead of saying, oh my God, why can't he figure that out, I should be helping him, because I should be recognizing that when somebody is asking for help, they really don't know, they want help, and that's what I'm there for, to meet the needs of my patients. And we should be responsive to, and we should be integrated with primary care. And this is where we still have quite a bit of work to do. Okay, now, having said those things, what do we actually do? This is a list that I made from a larger report that I assembled on the Department of Medicine. One of the things that we've become very, very good at is to establish these very specialized clinics where we provide specialized care for patients. Some of that care is in the outpatient setting, some of it is distance, some of it is just very, very outstanding quaternary care, okay? So for example, let me just pick one. Let's pick hematology, okay? So hematology is concerned with malignant hematology. So they will take care of patients who have lymphomas and leukemias and other hematological malignancies in specialized units. Joe Brandwein, since he came, has been focusing very much on getting these patients out of the hospital and treating and enabling their treatment for chemotherapy and also for febrile neutropenia in a medical outpatient setting. So that's just one example of how we're moving around medicine and how we're establishing highly specialized care. And you'll see much, much more of this when we publish our report online, our annual report online. Okay. And then, of course, I always like to mention that not only do we do the specialized care, but in a number of different clinics, it's actually and programs, it's actually being examined by people who do research. So this is research that was published this year, and this is on the Care Transformation Project that many of you know Ann Coburn launched when she was division director in general internal medicine, and this has now been supported and made sustainable by the team in general internal medicine, which is led by Narman Kassam. And then, of course, they have a few people in their division who are outstanding outcomes epidemiology and health services researchers, including Finlay McAllister. And they ended up getting together and published this paper, which has actually received some editorial attention in the press. So this is a way of getting us known for the work that we do. And this is an example of what we can do in every single clinic that we have. And, okay. And of course, we should also be thinking about the work that's being done in many of the divisions. And I'm just highlighting two, so please don't be upset with me if I don't highlight your own. But we know of the wonderful work that's been done in cardiology to reduce the mortality from acute myocardial infarction. Under the leadership of Paul Armstrong and his big team in cardiology, Edmonton is probably the place where if you're going to have an MI, you want to have your MI here in Edmonton because we have the lowest mortality worldwide from acute myocardial infarction because of the work that has been done through their leadership. Okay, and Paul was recognized this year through the receipt of the University Cup for lifetime achievement in this area. And again, just to go back to the Hippocratic Oath, I will practice medicine according to my ability and judgment for the benefit of my patients. We all do very different things. This is the end game. This is what we want to achieve. It's still true some 2,000 odd years later. Okay, and I'm now going to turn to research, and you'll see a few numbers, and thank you, Evangelist, for getting some of this to me. This is, how do we measure what we do in research? We measure it by quantity, and we measure it by quality. And quantity, a lot of times we look at funding. And why we look at funding is because you have to be pretty good to be able to obtain funding, especially in today's environment. But it's also a sign of recognition of what you do. The whole Faculty of Medicine and Dentistry receives approximately, $145 million per year, give or take some over the years, in research funding. Okay? The Department of Medicine makes up around 25% of that over the years. Okay? And so here we are. And biochemistry, by comparison, is a little bit lower. But when we factor in the number of individuals who do research at a level greater than 40% of their job description, it turns out that the numbers actually correct themselves. The Department of Medicine is very large, so just by sheer numbers, we tend to have a little bit more funding. And people know that there have been changes in funding. AIHS has come into being from AHFMR. They're now funding some research, some operational research support is coming from them. CIHR is undergoing yet another major transformation. There has been a shift of funding from more discovery research into more clinically relevant or clinically applied research. And so there's been this talk about, well, research funding is actually decreasing. Well, research funding in the Department of Medicine is bouncing around a little bit. The percentages at the top are the percent of research funding in the department as compared to the Faculty of Medicine and Dentistry. And what I've done here is I have these bars representing tri-council funding, which is at the bottom here. And we usually run around $5 million of tri-council funding in the Department of Medicine year over year. Clinical trials is the salmon color, and it bounces around quite a bit more than the tri-council funding. And then there are a number of other places where we end up getting funding, and this can be from the province, from foundations, etc., and from donors, and that too bounces around. But you can see it's a much larger proportion of funding when compared to the tri-council funding, which we hold so dear. Nonetheless, the tri-council funding, because it's so steady, tends to be the better measure of where we are, as how well we're doing as researchers. Okay, if this were to fall, we would be very, very worried. Okay, and then because our department is so diverse, we looked at only those individuals who have more than 40% of their position description reserved for research. We have currently 74 of our members with that kind of a job description. So that's about a third of our total. Only 47, this was a bit surprising to me, only 47 of the people with more than 40% research currently have a peer-reviewed grant. The total number of grants is 100, so those 47 often will have more than one grant. And there are some people in our department who have 3 or 4 CIHR grants, so that's pretty amazing. Now, this is a snapshot. We should probably be looking over periods of time because some people lose funding and then regain funding. Nonetheless, it seems to me that we might have a bit of a problem here. The average number of grants per these 73 faculty members is 1.4 per individual, and that should be closer to 2. So I think we have room to grow. The number with a CIHR grant is 29. The number with a salary award is 24, so that's not bad amongst this group. And then we looked at the number of publications, and this comes from the faculty. The data come from the faculty. So we have about 2.4 senior author publications per 73 for each of these 73 individuals, and another 4.2 that are co-author or first author publications. Nonetheless, 17 of the 73 this year had no publications at all. Okay, and so that's kind of surprising. Okay, and we probably have some capacity to move people around if they're still in a 40% research job description and they're not really getting any funding or publishing. So that's a place where there might be some capacity. Even so, our publication rate has actually been increasing over time. And I was really pleased to see that this year, even though our numbers of researchers are not that great, we're still growing. Okay, so things are not bad in the Department of Medicine. We have some outstanding scientists in the department, and again, I'm highlighting only a few. There are a large number, but I'm highlighting some of the very best papers that we've seen recently. So this paper, along with a paper by Paige Lacey last year, received the Department of Medicine Basic Science Publication Award. This paper, I was really pleased this year, is from one of our youngest stars. This is Peter Wang in the Division of General Internal Medicine. He had a PNAS paper, which was not contributed, but properly peer-reviewed for those of you who know how PNAS works. Okay, and so he studies the structural biology of troponin in the heart. And so that's a huge achievement. And then this year we also had a paper in Cell by Evangelos and Gopi Sutendra, whom we're trying to recruit back here. A paper in Cell is probably worth about 5 papers in other very good journals. So we're very proud of these types of achievements. Okay. Now I want to turn quickly to the graduate program in medicine. So we also have a very large graduate program where we have people who are getting their master's degrees and their PhDs. And again, here you see the numbers overall, okay? In 2013, so we're only up to 2013. I didn't have numbers afterwards. But we have around 60, 65 students in the program at any given time. This is not counting our postdoctoral students. So there's another 40. The program currently is administered through the department, and it is Sean McMurtry from cardiology who's the program coordinator. He meets with every one of the students once a year. He's done that group has done a huge amount of work on reducing some of the unhappiness of graduate students because some of their mentors were pushing them to the point where they didn't really flourish, and so we've made some major corrections there, and we have actually data that show that the graduate student level of engagement and happiness has actually increased tremendously. Okay. We've established, again through the work of Evangelos and the people in the research office, a new master's program in translational medicine. That started, it was accredited by or approved by the Faculty of Graduate Studies and started in the fall of 2013. It's in its 4th semester. And here's something I wanted to highlight, actually. we have a number of residents who are participating in this program. So this program is actually a wonderful way of getting some research training for our residents while they're still in their residency, okay? Because it's a course-based program, and they can actually earn their master's degree. This is also something that people can do who are in between their clinical training and getting an academic career. They can earn their master's degree right here at the University of Alberta or elsewhere to get some appropriate training to launch an academic career. There are some plans in the way to link this with other graduate programs nationally. So we're very, very proud, and we hope that this program will in fact flourish over the years. I'm going to talk a little bit about the ARP. So the ARP, I have the handwritten notes of the faculty of the department chair who was involved in creating the ARP. That was Tom Mary, and before him, Paul Armstrong. They actually got together, and there's a whole bunch of papers in the Department of Medicine, which we probably should put into a museum, that state of, what this is all about. And it comes back to what I talked about at the beginning. What is academic medicine, and what does fee-for-service normally pay for? Well, fee-for-service doesn't pay for a lot. It certainly doesn't pay for research, and it doesn't pay for teaching generally, and it often doesn't pay for administration. So the ARP, the academic ARP, was put together in order to achieve a few things. And the first one was to optimize clinical care delivery. So it was specifically designed to establish these multidisciplinary care clinics for complex diseases. It was designed to provide support to rural and northern communities. It was designed to increase the ambulatory care that we give to patients, not just in internal medicine, but elsewhere. And it was also designed to help achieve a really state-of-the-art program where we can do high-complexity procedures, which are often not paid for very well fee-for-service. It was also designed to enable research and to enable us to actually recruit researchers, and has been tremendously successful in doing this. It was also designed to enhance the ability of the department members to deliver on education. And it was designed to provide some sense of financial stability. So government can look at the ARP and can know ahead of time approximately how much it's going to cost. There are some issues here. We need to find an equilibrium. But these were sort of some of the thoughts that went into the development of the ARP. What about the numbers? So the first bar here is what it looked like in 2001, 2002. So there were less than 100 people on the ARP. The growth was very, very substantial over the ensuing 6 or 7 years. So we're almost doubled our numbers by 2010, which is right here. So we're now at 180. But note what's happened. It's the numbers have remained pretty stable. So since I've become chair, there have not been added positions to this ARP, and we've had to manage within this funding envelope. It turns out to meet clinical needs, therefore, we're increasingly developing divisions that are blended with people providing fee-for-service work and people providing ARP work. And looking at this funding model will be very important for the future. I think there are some opportunities. By position description, we have various different position descriptions. We have some people that do predominantly clinical work with some administration. We have other people that do predominantly research with little bits of other types of service. And we have people that do a little bit of everything. And when you look at the mean, this is the distribution of work that is supported by the ARP. So approximately, not quite half, no, I'm sorry, a little bit over half, depending on where you cut this teaching piece, is provided for clinical service. About 30% is provided for research, and about 20% for administration. And in my view, administration is probably a little bit high at this point. Our revenues come from various sources. So for those of you who don't know, there is a physician services budget which funds the ARP, and that's based on just physician numbers. So we get a set amount of money for every FTE that's in the department and is a member of the ARP. We have this little salmon-colored piece, which is AHS funding. So AHS gives us some funding. We have the green piece, which is university funding, and then this mauve piece is what our conditional grant looks like. So we get money from government to make up the difference between our expenses and our other funding. And this is problematic because this piece has grown more than the other pieces have grown. And government is looking at that. In terms of our expenses, in case you are wondering, most of it is paid for physician compensation, around 80%. And the rest is paid for the administrative services, so the secretaries and the administrative corps. I'm running out of time, but basically when you look at the increase in funding, over the 5 years, the physician services budget has grown by about 7%, and the conditional grant has grown by about 8%. So the difference is there, but it's not enormous. In terms of compensation, the physician compensation has grown by about 7 to 8% per year per FTE over 5 years. And the support staff compensation, this is both by number and by the amount people are earning, has grown a little bit more. But because it's such a small fraction, it doesn't have as much of an impact as the growth in physician income. Nonetheless, the numbers are all around 6, 7, 8%, so they're not really that different one from the other. Major challenges we've met over the years. We have had, and we have our new dean sitting in the front row. Welcome, Richard. We have had, you're my fourth dean since I've become department chair in 5 years. A lot of change in the dean's office, and we're hoping for some stability here. But there were a lot of challenges that had to be met because the deans often have their own ideas of what to do, and then we have to follow suit. And it usually takes resources, it takes time to do that work. There have been huge amounts, many reorganizational steps in
There are 10 minutes remaining in this video conference session.
In AHS, as you know, and it has led to some discomfort of how we actually work with AHS. There are also budget constraints within AHS. We can no longer go to AHS and just say, by the way, I have this super duper new way of doing endoscopies. Please give me more money. We have to find the money ourselves. There's incomplete alignment between the academic and the clinical departments of medicine. So cardiology and neurology are in a different clinical department than the rest of the subspecialties. So is rehab medicine, by the way. Okay, so those are challenges. We've met university budget cuts. We've lost positions because of these budget cuts. There's been an elimination of the AHFMR investigator program. So we had over 25 people in the department funded through AHFMR, all of which had to be somehow dealt with, and people had to be absorbed into the ARP. And the ARP has its challenges. The positions have been capped. There are funding constraints, and we have challenges to demonstrate to government what the value is, and we're working on that piece as we speak. What have we achieved? This is in no particular order. Multiple Sclerosis Center has been established. We have outstanding leadership in many of the division directors, associate chairs, and other members of the department. We are maintaining academic output despite budget cuts. We've introduced clinical quality improvement projects, and this is actually a major emphasis in our strategic plan. We have emphasized the achievements in educational scholarship, which was a part of the strategic plan 5 years ago. All of our residency training programs are accredited. We established a new division of preventative medicine in order to salvage the public health, preventive medicine and public health residency program. We have a very strong and lean administrative corps. In the last 2 years, we've lost 5 people from the administrative corps, but we are better than ever. We're getting our grants and projects handled within less than 24 hours. It used to take 5 days. Recruitment processes in the department have been streamlined, although I have to say that that's often balanced by increased bureaucracy that we have to meet, for instance, right now from immigration. We have a very, very strong career mentoring and progression program. And not to leave this out, there's been the space planning project, which is kind of happening in the background, where we're renovating and moving almost all of the divisions into the clinical sciences building, which is quite a bit of work. And thank you, Tim Bulger, for all the work you're doing on this. So our strengths, I think we are truly a translational department. We have strength across the spectrum of research. One of our strengths definitely is that we're funded through the ARP. Some of the other clinical departments do not have ARPs, and they are struggling with being able to meet the academic needs of their departments. We have a lot of leadership strength. We have a strong emphasis on career development. We have a large number of clinical academic colleagues which share the teaching, and we have a well-honed administrative corps. Those are probably just some of our strengths. There are some weaknesses. We still have a culture of going it alone. There is definitely still an incomplete understanding of what academic scholarship is all about. We have many people who I would consider to be emerging leaders. Many of them are reluctant to lead in the current environment. How do we change this? Okay. AHS, clinical and university academic departments are not aligned, and the departmental leadership therefore is sometimes out of the loop, so we don't always know what's going on. So that's a definite weakness. There are operational challenges in the Edmonton zone. This is something important. Increasingly inefficient electronic information handling. We have a lot of tools. They're all incompletely developed at this point, and they need better development. It makes us inefficient. The ARP accountability metrics are not aligned with the ARP goals, and that's a weakness, huge. And individual accountability is also difficult to implement. The FEC and ASHUA, there's a bunch of barriers in place which doesn't allow us to do this really well. I've put the threats before the opportunities. Obviously, budget and funding is a huge threat right now with the price of oil having halved in the last few weeks. We have a threat in terms of sustainability of the workforce. We are quite top-heavy. In a lot of divisions, we have an aging workforce, and it becomes more difficult to recruit when you have funding problems. There's also an increase in clinical demands without growth of the workforce. In education, we have some threats, and that is the Royal College and the Medical Council of Canada. I don't think they're really totally, and this may be heresy, but I don't think they're really totally accountable for what they constantly ask us to do. They're constantly asking for more people, but they don't have to pay for those people. We do. And so when they say you can only get accredited for this or that if you do X and Y, we have no way of dealing with that. We just have to put more people in place. And it really is a problem when we're limited with workforce. There's also, I believe, another threat is the reduced emphasis on the content and knowledge. You know, so there's a huge emphasis on what kind of a physician you're going to be, which I think is important. Don't get me wrong. But frankly, I also think doctors should know what the mechanisms of disease are and what the mechanisms of action of some of the drugs they use are. And that's kind of getting de-emphasized. And I think that's a threat. We have a lot of opportunities in education. We should be studying outcomes in education wherever there is a change. So we're looking at changes, and we should be studying those. Okay? We should be strengthening the mechanism-based medicine curriculum by having some input, and we need to see the e-learning tools as an opportunity. In clinical, there clearly is a move towards tertiary prevention, so getting out of the hospital and helping people with chronic illnesses to live a relatively stable life. And that's a real opportunity to study. Again, ambulatory care, all of this stuff can be studied and can be published so that we know eventually when we do these things, are they really working? Our IT systems, what actually works? This is a huge opportunity for study. And again, the quality improvement, which we've already said are initiatives that we want to embark upon. In research, we have a great opportunity because we're such a translational department. And this is also where the funding opportunities are increasing. We have some very strong basic science in the Faculty of Medicine and in this university. So think about prions, structural chemistry. There's a lot of other stuff going on. We should be hooking into those opportunities. Our graduate program is definitely an opportunity. It's an opportunity for training not only of residents, but also our faculty. We have a tremendous diversity of research here, and we need to build teams. We need to take this opportunity to build teams. Another opportunity is the Alberta Advantage. We have access to a huge population base that doesn't go anywhere, except in the winter when it's too cold. And so we need to study this population. We also are a unique gateway to the north for clinical research. So we should be studying, and some people are, the underserved populations, how distance medicine works. The university has tremendously developed core facilities, including the new cell therapy manufacturing facility, which most of you don't know about. And again, we should be taking these as opportunities to expand. In administration, we need to preserve and renew the ARP. It is critical for our mission. We have this ARP-funded administrative core. We're doing this work, but here is an opportunity to help define and eliminate wasteful bureaucracy, not only in the department, but in the faculty. And these are some other opportunities. So, you know, as always, I went on for way too long. I didn't leave enough time for questions. But I want to thank you again from the bottom of my heart for working with me in the last 5 years. And maybe the review committee will think that I might serve for another 5 years. I'm certainly ready to roll if you'll give me the chance. Thanks.